All right, hey guys, y'all ready to get rolling? Might as well. We got 35 here, so had a few more trickle in, and I've got it where people can come in as they get here, so we can go ahead and talk about test 3. If you didn't read the chat, read that, please. Let's see. So we're going to talk about chapters 8, 9, 10, 11, and 12. And the best way I think to do this is for me to get a little bit of participation from you guys. It will make it better. I see some of you have found your way outside. That looks like a nice place to be today. So let's jump right into chapter 8. Somebody tell me the difference between orthopedic and neurological impairments. What's an example of an orthopedic impairment?
An ACL tear?
Yep, absolutely. Thank you. What about neurological? Somebody else?
Like a brain injury or
Yep, brain injury. We talked about brain injuries. There's open and closed brain injuries. And open brain injury would be something like a gunshot, or if something impaled into someone's head. A closed brain injury is where you have like not something that penetrates, but it causes swelling, bleeding in the brain. Okay. What if someone has hemiplegia? What are they experiencing?
One side of the body is affected?
Yep. One side of the body split down the middle from your, down the midline. It's going to be on the right side or the left side. So if that's the case, what about paraplegia? Where would you be affected?
The top or bottom?
Generally, the top is going to be unaffected. If one is unaffected, it's usually going to be the legs, because it's whatever is below the area of injury to the spinal cord most of the time. So people will have use of their arms, hands, head control and things like that, but they may not be able to move their legs. That would be paraplegia. Quadriplegia is all 4 limbs are affected. You guys know that. We talked about traumatic brain injury. Know what happens when you have traumatic brain injury. One thing that just comes to mind that I want you to remember, if you're ever working with someone who has TBI, is going to be that one thing that they've shown, that I've seen this in person, is kind of this unpredictability and a bit of inappropriate emotions sometimes. Like for example, they can start laughing at a funeral, totally inappropriate, just emotions can be thrown off. That's something that I've seen. We talked about cerebrovascular accidents. What's an example of that? The main one that comes to mind.
A stroke?
Yep, absolutely, a stroke. All right. One thing that we've talked a lot about being beneficial for most every one of these groups that we talked about is aquatic therapy. So note that as being a good form of treatment to use. It helps people who are unable to, walk on their own because of balance issues, because they can't support themselves. The buoyancy gives them an opportunity to do things that they can't do on land. Makes their limbs lighter, easier for them to raise and things like that. So aquatic therapy is a good tool. We also talked about animal assisted therapy. What are some examples of animal assisted therapy?
Hippotherapy.
Yep, hippotherapy, good job. What's the difference between hippotherapy and therapeutic riding?
Therapeutic riding has more responsibility and trust with the actual animal, and hippotherapy uses the horse's movements to promote the person's like trunk
Right.
mobility
Mm-hmm.
and muscle.
Trunk control, stability, and again, when you're doing hippotherapy, you're on there. The pelvis of the horse makes the person who is on the horse makes their pelvis move exactly the same as if they were walking, which is really pretty cool when you think about it. If you're just on top of the horse, it does the same thing as if you were walking, and you have to maintain trunk control and balance and things like that. And you're exactly right on the differences. Hippotherapy, that's strictly what it basically is. You're working on specific things like balance and trunk control and things such as that, where therapeutic riding is a little bit more for fun. You spend more time with the animals, grooming, feeding, petting, things like that. So it's more of a little more recreational in nature based. It is therapeutic, but it's more mood related than it is physical related. On any of these chapters, if you want to prepare ahead, I just have a note here for myself that if you kind of want to do some prep prior to taking the test, you can look at the discussion questions at the end of the chapters. They usually have good questions that give you a good idea. Some of the discussion questions may end up on the exam anyway, so it wouldn't be a bad thing to look over. That's all I've got written down right now for chapter 8. So we go to chapter 9, and we're talking there about developmental disabilities. This was the one where we had all the videos that we were going through. You need to be able to recognize the cause, symptoms, what's going on, like what is, when someone has Down syndrome, what is going on with them? Can anybody tell me? They have an extra something.
Extra Y chromosome.
Yep, they have an extra chromosome. Fragile X syndrome. Does anybody remember what Fragile X was all about? That was the video of the two brothers where they were just kind of picking back and forth at each other. Not the best video, but it was the easiest one that I could find. It is, you need to remember things like it's Fragile X is more severe in males. That's something to know. It's the most common inherited form of intellectual impairment. And what happens with Fragile X is the body produces insufficient amount of protein for the body to develop appropriately. That's what's going on. It has, they have behavioral problems similar to what you would see with autism. Back to Down syndrome, that's the most common chromosomal developmental disability. It's caused by an extra chromosome. And they have things like premature aging as an adult, slower physical and mental development, visual problems, poor muscle tone, things like that. Okay. Phenylketonuria, PKU. Who can tell me what that is?
It's an inherited metabolic disorder.
Very good, thank you. And the key on this one is remember that the body can't break down the protein phenylalanine. That's what's happening, and when the body receives too much of that particular protein, then they can get brain damage. That's what's going on there. They can treat that with a diet to limit the amount of phenylalanine. Let me see what else here. Okay. Okay, an IPP is what? Does anybody remember? In regard
Individualized personal program.
individual program plan, yes, very much close. So in an educational setting, people have something similar, and we talk about these people who have developmental disabilities, and they're trying to, they're being placed in, regular schools and all, and they get IEPs. Everybody gets an IEP, which is just an individualized education plan. So know that they get that in school. We talked about behavioral modification during the chapter. Also, in how we work as a team with psychology and the direct care staff to try to do things to model appropriate behavior and things like that for people with developmental disabilities, because a lot of times they can learn a lot better by seeing things done the right way than they can from just you telling them. They may not be able to process language as well as you or I can. Autism. Somebody tell me about autism.
It's the most common pervasive developmental disorder.
It is. It's neurological in nature. And what kind of things are you going to see in a patient who has autism?
Lack of social or emotional reciprocity.
Reciprocity. That's a hard one. Yeah, they're not going to give you back what you give them necessarily. Like if you smile at them, they may just look at you flat-faced. One of those kind of awkward moments, you have to be again, this is a group that you have to be careful with what you say. You can't use like euphemisms. You have to say things exactly what you mean, or they'll take you seriously. They, a lot of times they do stereotypical movements. It may be sitting here doing this. They may just want to sit in a chair and put their finger in front of their face and do that because that just stimulates their brain. They don't really, you see this at a young age, they don't really participate in make-believe play. They are the child that's in a playpen with 15 other kids, and 14 of them are fighting over one toy. And this is the kid that's sitting by himself over to the side, just rocking back and forth. That's a good indicator early on that something is going on, that they're not wanting to play with others necessarily. They don't want to, they don't do a lot of pretend play and things like that. Everything's very literal with them. So pretend play doesn't really fit the bill for this particular population. So just for an example, I'll run through this for you for autism, but these are the kind of things that you need to kind of know for these groups. Therapeutic recreation for people with autism and other pervasive developmental disabilities. We want to do things like that can help them improve communication, work on social skills, daily living skills, and try to improve behavior. They have sensory issues a lot of times, so we want to use sensory inputs with them. We want to have them interact with peers that don't have disabilities. That's important for modeling appropriate behaviors. There's relaxation rooms that are used for individuals with autism where they can actually reduce sensory overload. It's like I said, for an example, you know, if my light in my office was buzzing, eventually, you know, I wouldn't notice it very long. Probably I'd be able to kind of tune it out. They would not. I worked with clients at NMRC that I promise you they could hear a clock ticking, like, or they wouldn't stop watching the second hand on a clock. That was something that just triggered to them to stick with it. They could not move away from watching the clock if it was there. So if you wanted to get anything done, you had to move the clock, take a clock down, things like that. So think about, with each of these groups, appropriate therapeutic interventions that you could do with these people, and maybe even, you know, what are some things that you shouldn't do with them. I'm not going to go super deep, you know, ask you to list 10 things for everybody or anything, but just kind of know what their symptoms are and what you need to work on, as, you know, if you were doing recreation therapy with them. Let's see. Cerebral palsy. What's going on there?
Inability to control muscular and postural movements due to brain damage before age 12.
Good job. Before age 12. And there's different causes of this. It could be genetic, so certain infections, child abuse, stroke, head injuries, and there's different types. You need to know the differences here on these types of cerebral palsy. You've got spastic, which is the most common. Know that. That's 70 to 80%. And that's the one where muscles are extremely rigid and tight. You know, your arms may be drawn up tight, your legs are drawn up tight. And you literally, I've been there and done this with them in the pool before. I would try to stretch their arm out, and it takes a long time to get any release. And I'm a pretty big guy, and I could not, you know, you'd feel like you're going to break their arm if you move it. That's how tight the muscles are. So it's really, you can imagine how uncomfortable it could be, you know, when you're that spastic, and that is the most common form. And again, 3 different forms of spastic. You've got diplegia, which is only the legs, hemiplegia, half of the body, one side or the other, and then quadriplegia. So we've talked about that. Just the opposite of spastic is the athetoid form of cerebral palsy, and that's low muscle tone, slow, uncontrollable movements of the body. So rather than being super rigid, super tight, they have no muscle tone at all. So their movements are just slow, not very precise. If they reach to pick up a cup, they're probably going to knock it over. The same thing is seen in the third type here, ataxic. These individuals with CP have a poor sense of balance, trouble controlling their muscle length or their position, and again, may overshoot when they're reaching for objects. You know, they get started reaching and it just keeps going because they don't have that good motor control, because of the damage to the brain is interrupting that proper control of the muscles. So the things what things are affected by cerebral palsy? What do we have to look for as recreation therapists? What sort of things are we going to see? What can they not do? What will they have trouble with?
Walking,
Walking, yes.
riding,
Yep, writing, fine motor skills,
Balance.
such as writing, balance, just name that, that's right. Communication is even affected. You know, you have a lot of muscles involved with communication, so they have trouble with that as well sometimes. Several of these have higher incidences of seizures as a possibility, especially the ones that have issues with damage to the brain. You know, that's going to tie directly into the possibility for seizures. So higher incidence of seizures. When someone with cerebral palsy overexerts themselves, their symptoms a lot of times get worse. So when we're doing activities with them, we got to watch out to not overdo things and possibly make them worse than they are. And a lot of times with CP, I say a lot of times, not, I'd say it's a higher risk, as it's listed on the form, higher risk of obesity due to inactivity. They don't have balance, they have trouble walking. If that's the case and you're still getting all the food you want, obesity is definitely a possibility and a probability. Probably the best thing to use as far as recreation therapy for people with CP is therapeutic horseback riding and hippotherapy. They're two of the best options. You can also reduce imbalances, like if they're tighter on one side than they are the other. You can do things like they can have massage, they can have stretching, trunk rotation. Warm water aquatic programs are also good for this particular group. That's enough on that. Spina bifida, what's going on during spina bifida? What's the problem?
spinal column getting closed during gestation.
Good. The spinal column did not close during gestation. So this stuck out to me and was surprising the first time I saw it. 40% of Americans have some form of spina bifida. So some of you in this class have it and don't even know it. Some very, very mild, light form. You know, you would have to have another injury or something to warrant an X-ray that would probably to ever even find it out. So it's relatively common. 90% of people live a normal life that have it. Now there's 3 different types. You need to know the difference in the 3 different types here of spina bifida. Occulta, meningocele, and myelomeningocele. Which one is the worst?
Myo.
Yeah, there you go. Good enough. Yeah. Spina bifida occulta sounds the worst to me. I don't know, you think of the occult being like a bad thing, I guess. That is actually the mildest. And then meningocele is can be treated. It's the middle of the road. And then there's myelomeningocele, where someone actually, that's the one where someone is identified as having spina bifida. They're probably going to be in a wheelchair, things like that. The good thing is that that's only in 1 out of 1,000 children. Most of the time there's paralysis below the exposed area. So if you're going to have it, you want it to be lower rather than higher, obviously. So know the difference in those 3 types for sure. Muscular dystrophy, we also talked about that. There are some different types. Tell me what's going on with muscular dystrophy.
Hereditary or mutated gene on X chromosome.
All right, good deal. It is shown by progressive degeneration and weakness of voluntary muscles. So that's muscles we're moving on purpose to do specific things. As therapeutic recreation specialists, you want to try to work on improving movement, flexibility, and a lot of times with this group, you have to adapt activities for participation. Special Olympics, for example, there's they have Special Olympic basketball, and there's a whole gym usually full of clients that are of athletes that are playing games, actually like 3-on-3, 5-on-5. There's unified games. And then there's another gym that's usually full of people who are doing what's skills. And what that may be, a lot of those individuals are in wheelchairs, and they're probably going to be no farther than 6 feet from a wall, and they'll put a square, they'll tape out a square on the wall, and the goal is to throw the ball into the square on the wall. There's some dribbling that happens, shooting for, say, someone who has muscular dystrophy, spina bifida, some issues like that, cerebral palsy. Shooting, they may shoot into a basketball. I mean, like a big gray garbage can, like you could picture. That's activity modification. That's making it where your athletes can participate, still get cheered for, still have a great time, but have adaptations where they can be successful. So that's important. Them being successful in turn is going to make them feel better about themselves. So we're helping them physically, mentally, emotionally, hitting a lot of different areas in that way. So the types of muscular dystrophy, what is the most common one, and really the only one that I'm worried about you knowing?
Duchenne.
Yep, Duchenne. It's the most common type. It's over half of the cases. It's the most aggressive. And remember on this case that muscular dystrophy is, a lot of times as a recreation therapist, our job is to try to keep them where they are, to try to keep them to slow down the debilitation, to help them be able to write for as long as possible. Things that we can do, if we can just hold them where they are, we're successful. You're not going to stop the progression. It's progressive, obviously. Duchenne is the most aggressive. You're going to start seeing signs around age 2. They're wheelchair bound by age what?
12.
12. And when do you usually see death?
Early 20s.
Early 20s. Very, very sad deal here. It's not cool at all, especially when you have a child that, is perfectly normal, for lack of a better way to put it, for 2 years, and then you see some things start going on and you find out they have this. Before you know it, they're 12 and they're in a wheelchair. It's this one is really sad to me. Always, when you're talking and working with people who have developmental disabilities, remember to talk to the person, not to their disorder or what they have going on. We always want to promote leisure to them, and the fact that it's important, and it's a good way to help their self-esteem, because a lot of these people's self-esteem is not going to be the highest. Always keep in mind this least restrictive environment that we've talked about. That's just simply we're doing what we do the very least that we have to help them be successful. We let them do as many things for themselves as they can. That's kind of the key on least restrictive environment. All right, let's move on to chapter 10. And let's talk about it. Sorry, I've got multiple sections of notes here I'm trying to find. So I've got on my notes here IPP. What's an IPP again?
Individual program plan.
Yep. We're talking about kind of, for the most part, mental disorders in this chapter. There are mood disorders. What are some examples of some mood disorders?
Bipolar disorder.
That would be one. Yes.
Manic. Manic.
Yeah, like manic depressive mania.
Yeah.
Just also remember that DSM-4-TR is the system that they use medically to diagnose mental disorders. If you see that, just be able to recognize it. We talked about the importance of multidisciplinary teams and how we need to communicate with each other and work together for the betterment of the clients, not against each other, not sometimes having to put aside a little bit of pride of thinking that we're the most important rather than another group being the most important. So just something to think about. So our individualized program plan that we put together for people as recreation therapists goes together into a comprehensive treatment plan, which is where the whole group puts together a large document saying, okay, this is what nursing is going to provide. This is what resident living is going to do. This is what psychology is going to address. Physical therapy is going to work on this. Recreation therapy is going to offer this. And then you've got a comprehensive treatment plan, and that's what that's all about. It's where everybody has their IPPs basically put together into one large packet for the patient family to go over and agree to for a certain amount of time, usually a year. They have a meeting every year to go over that. Let's see here. So, major depressive disorder is one type of mood disorder. Dysthymia is another one. And then bipolar disorder. Does somebody remember the difference in major depressive disorder and dysthymia? We went over it.
Dysthymia is more persistent but less intense.
Absolutely. Good job. Dysthymia is, it like hardly goes away, but it's not as debilitating of a depression as you see in major depressive disorder. And bipolar is where you see manic depressive episodes. Someone's either really high or really low most of the time. That's what you see there. Okay, anxiety disorders. What are the main two of those? Tell me what agoraphobia means.
Places make you anxious.
Basically, yes. Places or situations make you anxious. And these are the people that a lot of times when untreated, touched end up being hermits. They don't want to come out of the house. They want to stay home. So that's agoraphobia. They either have a place that they're afraid of or a situation that they're afraid of most of the time. Social interaction may be the thing. If that's the problem, then they're not going to want to go anywhere. So then you've got panic attacks. Those are pretty common. I'm sure there's people in the class that have had panic attacks. This has both physical and mental side involved in a panic attack. Anybody tell me anything more about those? Kind of a symptom, basically, of anxiety disorder. I think we all kind of know what they are. Just know that two of the common symptoms of anxiety disorders are agoraphobia and panic attacks. And they have common forms that they're shown in, and that would be panic disorder, where you have these panic attacks on a regular basis, and then obsessive compulsive disorder. So what is the difference between obsessions and compulsions? When you have obsessive compulsive disorder?
Obsessions are more like thoughts, repetitive thoughts, and then your compulsions are the physical action of locking the door 3 different times.
Absolutely. Perfect. Thank you. Yes, obsessions are thoughts. That's your head won't be quiet. Compulsions are your physical activities that you're doing to try to get rid of those obsessions, to try to calm those thoughts, whether it is checking the door 10 times before you can walk away. You got to make sure it's locked. You got to make sure it's locked. Did I turn the stove off? Things like that. Also, another type of anxiety disorder is PTSD, post-traumatic stress disorder. We all know that that's, generally caused by some sort of major event. We hear about people coming back from war with PTSD, people who have been abused, people who have been raped, people who have seen bad things. I'm sure that people who survived the attack on the Twin Towers, a lot of them have anxiety and PTSD from that. The ones who got out, and knowing that their friends didn't. Let's see. Okay, let's talk about eating disorders. Tell me what anorexia is.
People won't eat because they're afraid of getting fat or they feel like they are fat.
Generally, that's the case, yes.
It's physical as well as mental.
They look in the mirror, they may be severely underweight, yet they can look in the mirror and see something totally different than what you and I would. They still think they're disgustingly overweight for the most case. What's going on with somebody with bulimia?
They binge or purge after a specific type of food. They're usually within a 10-pound radius.
Good. So if you were to walk into a room, could you pick out someone who is anorexic? Probably.
Yes.
Yes. Could you pick out someone who is bulimic?
Probably not.
Probably not, because they're going to be within 10 pounds of the recommended weight most of the time. That's the main difference that you see here. They're both eating disorders. People with bulimia usually are not severely underweight like people who have anorexia are, for the most part. That's the main thing to note on those two. I've always said that I'm half bulimic, that I like to do the binging part. I just don't like the purging part of it. I like the eating. I just don't really like throwing up. So I don't guess I have to worry about the eating disorders on my end. Unconditional positive regard. Can somebody tell me what that's all about? It's very important as a recreation therapist. It's something you need to have, especially if you're going to work in situations like, say, a correctional facility or a juvenile delinquency center or a substance abuse recovery type setting. Unconditional positive regard.
Thinking that everyone's good.
Basically, you just nailed it. I mean, it's giving everybody a clean slate when they come into you and saying that everyone is a good person, but the things that they do may not be good. That's you're giving them the benefit of the doubt that they can be better than what got them to where they are. You're kind of giving them a clean slate when you're giving them this unconditional positive regard. Let's see. Okay, we talked about some theories, and there's not much I can do other than just have you look at those, the attribution theory. There's a self-efficacy theory. Make notes of those. Anybody want to tell us what those are? Anybody have any idea?
Attribution is how people perceive their success and failures and the consequences of them.
Yep, that's right. They have to, that's what they attribute them to. It's kind of like, well, this is why. What about self-efficacy theory? You probably have it right there. You can come on with it if you have it.
It's like, do I think I can do it?
Yeah, if basically that's something that we want to build in people, is, like I say, by giving them things that challenge them, but they're able to be successful in, we're going to improve their self-efficacy rationale. They're going to feel like I'm able to do this. I'm efficient. I can do this thing. So we can influence that in a positive way through recreation therapy by finding that proper amount of challenge and yet letting them be successful. Okay, we talked about something that do you guys remember what transference and countertransference were when we're talking about working with people in this population?
Transference, it happens whenever a patient associates the therapist with somebody from their past. It's usually relating to mental illnesses. And counter transference is they start to resent you, the therapist, because they see you as somebody that's like negative from their past.
Yeah, you got most of it exactly how I want you to take it. Transference is when is more about the client than the therapist. They start to see you as somebody or something from their past. They relate you to that. So that was 100% right. Counter, and that can be either a positive or a negative. If they are associating you with something positive, then it won't necessarily be a bad thing. As a therapist, you want to stay away from countertransference, which is where the therapist starts to associate a patient with someone or something from their past. That's basically never a good thing. So just something as far as definition wise, I want you guys to remember also from this chapter. At the end of the slideshow, there's a list of, or the PowerPoint, there's a list of different modalities. What's a modality?
Tool.
A tool, what we use. It can be a game, it can be an activity. Whatever we do to address the issue is our modality. Leisure education, values clarification, which we want to make them see what's important to them. Stress management, self-esteem programs, expressive therapies, those are all good things to use with people who fit in this category. So I think we about covered mental health. Chapter 11, it was a little shorter. We talked about youth and recreation therapy. What is an at-risk youth? What causes a child to be determined to be at risk?
Poverty.
Poverty is a good answer, a good possibility. Coming from poverty. What's something else?
Depression. Being in a gang. Alcohol.
Yep. Bad situations at home. A lot of times, single parent household, if they are having to take care of themselves and siblings, that could be a tough situation. Where you live can play a large role. Peer pressure comes into play a lot, gang activities and things like that. So 50% out of 71.7 million were considered to be at risk. So it's obviously common. There was a continuum that we went through from minimal all the way to at risk. Minimal, remote, high, imminent, and at risk. And the ones who are in the last two categories, imminent and at risk, showed the most inappropriate maladaptive behaviors is what we saw. What is an ecological system? Simply put, what is that?
Relationship.
Relationships. What else?
Environmental interaction.
Yep. Basically, your environment in general, what you are exposed to, where you are, who you're around, what you're doing, your environment. You're talking about that. We're saying ecological system for a bullfrog would be a pond, lily pads, grasses, water, fish, snakes, whatever. That's same thing for people. We have ecological systems also. So just something to think about. We talked about social capital. What is that? It's a theory. What does social capital theory say?
Humans are
They're
better.
better when they're together.
Yep. People do better when they are bonded together with other people. That's the theory. So youth that have more social bonds, they have social networks that support their success, which is going to promote them to try to be more successful and act appropriately. Something else very important. What is flow? Who can explain in the recreation therapy setting what flow means?
When you have the clients doing something that they're really, I guess, using just different word, they're in the zone, say,
Yep.
If you're doing a sport activity, they're really focused on the sport, on the sport activity that they're doing and not really
Very
thinking
good.
about other things.
Nice. You just nailed it. They're not thinking about anything else. They are immersed in what you're doing. So you want to try to come up with things that will get people to this state of flow where they're not worried about what's happening at home, where they're not worried about other things. They are focused and time flies by. And, you know, you've all been in situations where you have been in a state of flow. That's what flow is all about. What's a good type of therapy we talked about to use with youth? It doesn't have to be this one that I'm thinking of. What are some good things that we could do with youth?
Adventure therapy.
That's it. That's what I was looking for. Adventure therapy. Most of the time it's going to be outdoors, which they're going to like. It's going to have that adrenaline rush that a lot of kids are going to look for. You get them, you know, high ropes courses and things like that would be adventure therapy. Whitewater rafting. If you're whitewater rafting with the group, are you going to be thinking about things at home at that moment? Probably not. You know, you're going to be thinking about not falling out and hitting your head on a rock or something like that. You could probably get flow in that situation. It could be hiking, difficult trails, things like that, things that are going to challenge these kids. That's enough for that chapter 2. Let's go to 12. And 12 was talking about the elderly. And again, I should have had my papers in a better order before I got started. I'm trying to pull those. No, I'm just going to rely on you. Never mind. I found it. All right, aging in the lifespan. So we have, again, some more theories that we talked about. And these are the things that theories are not my favorite thing to talk about. I'd rather talk about how we can help people, activities we can do, what's going on with the patients that we might see, much more so than talk about theories. That's kind of like talking about history. To me, it's kind of boring, but it's still kind of need to know things because you can base what you're doing on that. So there's some theories for successful aging. Tell me about activity theory versus disengagement theory.
Activity
Right.
theory, disengagement theory.
Yeah, the activity theory absolutely refutes the disengagement theory. So what does the disengagement theory say? What is that? And this is one that I hate, actually. I don't believe it, and I don't know how someone could really even have this theory.
People enhance life satisfaction by decreasing emotional ties with others in society, and they become more self-occupied.
So they can enhance their life satisfaction by becoming a hermit is basically what it comes down to, the way that I read this. I guess for some people it may happen. You may know someone that may have done the disengagement theory, but for most, I don't think it's the way to go. The activity theory is just the opposite. It's saying that older people are happier when they're active, engaged with life, and energetic. So we want to, through recreation, help them to find meaningful leisure. And just a note, everything we're talking about today is not necessary. Every single thing we talk about isn't going to be on the test, obviously, but these are the main points that I want you to take from these chapters. So that's why I'm going over them one more time, because I want you to take this stuff with you, that you can actually remember some of it. I know it won't stay forever unless you're using it all the time, but it's at least it's good to go back over it one more time. Continuity theory. Somebody read me that. I didn't mean that as a slight, by the way.
People develop habits, attitudes, preferences, and relationships while growing old.
Yep. They basically saying that as they are growing old, that they already have habits, they have attitudes towards things, they have preferences and relationships, and that maintaining all of these things and keeping them where they are is important as people age. So it addresses the fact that everybody's different and everybody has personal differences in all these things, like their habits and attitudes and preferences. They're basically saying it's going to stay that way when you get older, as long as you stay engaged doing those things. That's what that's about. What are some settings you might work in with elderly patients in therapeutic recreation?
Veterans home.
Veterans home. I knew that one was coming. Good.
Nursing home.
Nursing home. There are specialized facilities for certain things. Is there anything that sticks out? They have units in nursing homes for patients with
Dementia and Alzheimer's.
There you go. Dementia and Alzheimer's. Very good. Those are the main places. You also could work in like the adult, adult day programs is another place that you could work. Assisted living facilities. Tell me about an assisted living facility. It's different than a nursing home. What sort of living conditions does someone have if they are at an assisted living facility?
They still live alone.
Yeah, they still live alone. They do usually live, it's usually kind of like an apartment complex. They have their own apartment. They have a lot of individuality still left, a lot of freedom. They can do things that they want. However, these people do need some help with some things, or they like to be in a facility with other people, close to their age. They may need help with transportation, things like that. Most of these assisted living facilities have pretty good recreation therapy programs that try to keep these people active. They also try to involve the families a lot, is one good thing about these facilities. They try to keep the families involved to come to special events and things like that. So when you go to a nursing home, what's the main reason someone would be in a nursing home versus an assisted living facility? The main difference.
Assisted living, you need less medical care usually. Nursing homes, you have to have basically around the clock care.
Perfect. That's it. It's the amount of medical care that you are going to need is going to determine that. Then for someone who's in an adult day program, where do they usually live?
At home.
Yep, at home or with a family member. And the reason that they go to these adult day programs is to give the family member or caregivers a little bit of a respite, a little break to be able to go to work and things like that. They're usually open early in the morning, say 7 o'clock to 6:30 at night, something like that. So they can be dropped off and picked up. I don't know, it sounds kind of, I'm not trying to be rude with it, but it's almost like adult daycare. Their family knows that they can be dropped off and taken care of and kept busy during the day, and that they're going to be safe when they come back to pick them up. And they can still continue to work and do the things that they need to do. So that's important. What's dementia? What do you see in dementia? What's happening?
very forgetful.
What's that?
They're very forgetful.
Yep, they start to become forgetful. Anybody else have any experience with dementia? Have anyone that is dealing with it or anything?
They repeat themselves a lot.
Yes. What's a good recreation tool to use with someone who may have dementia?
Arts and pets.
Yep, those are good for sure. Anybody have another one? What's something that can take you back to a specific time and place?
Music.
There you go. You nailed it. Music. Pets are good. Seeing family is good. Music is good. Arts and other ways for them to express themselves is good, because they may not be able to express themselves as well as they could at one point. You start to see things like aggression that was not there before. So those are a lot of things that you have to deal with when you're working with this population and be prepared for. You do things like reminiscent therapy, where you're trying to take them back to times and help them remember things. Another thing, though, is that a lot of times when you're working with patients who have dementia, they may be confused. You know, they may call you a different name every time you come in there. And if your name is Noah, and every time you walk in there, they call you Adrian, you know what the best thing to do is? Answer to Adrian, because it really doesn't matter. And they're not going to remember if you constantly are correcting them. So you just kind of have to know what you're getting into with this group. It's not necessarily a bad group to work with. It's a challenging group, but some people are absolutely cut out for it. You got to have some compassion to work with this group, though, for sure. The tests will be similar to the last one. I think there's a little bit more. If I recall, I made the test a little while back. If I recall, I think there's a little more like multiple choice, true, false, things like that. A little less of the, longer answer. However, please, 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 if there is an answer that you have to fill in, please put something in there and don't leave it blank. If you leave it blank, I should do more than give you 0 points. Give me some effort on those. If you have anything that remotely is worthy of credit, I will give you some credit. Okay? It's just do that. And on the true, false, multiple choice questions, read them closely. If they say, some questions may, one word on a true, false can make the difference. I'm not trying to trick you up, but that's how a true, false question works. So just read the questions carefully, take your time, use your materials that you have, and you should do just as well as you have on the other ones, or better if you haven't done as well as you wanted. So anybody have any questions or anything like that? I appreciate y'all for participating today, especially the ones that were very active with it. I hope y'all do well on the test. It will open up in 8 minutes, and it will be open through the 18th at 11:59 p.m. So get it in before that time ends, okay? All right, guys, if y'all don't have anything, good seeing y'all. Y'all have a good one. And let me throw this in here. Since you have the test and we're doing just fine on time, let's take Thursday off. How about that? Would that make y'all mad? All right, let's not have class Thursday. You can take the time that you would have been in class and do your test if you want to. So I'll see y'all next Tuesday, and I'll make an announcement that we're not having class for anybody who might not have been here today. Sound good? Thank you, guys. Y'all have a good day. See y'all.